Chapter 18 is going to be general pharmacology, and so we're going to talk a little bit about just some general information on the medications so you can understand them a little better. Some of the meds that you can administer, and then some of the meds that you can assist with, and then the last thing is going to be assisting with IV therapy. So again, it goes along with you may have a paramedic partner that can do more than you, but you need to kind of have a baseline understanding on some of these things, similar to the advanced airways in the airway chapter, so that you can assist when the time comes. The medications that we're going to cover are the basic EMT basic medications. Your individual system that you can work in, they may have additional medications that they would train you on specifically. Each system is a little bit different in how they operate. From a national standard, though, these are the EMT basic drugs. Don't be surprised, though, if you will see other medications when you're out in the field. So I did rearrange the slides a little bit compared to your textbook. From an educational standpoint, to me it's a little bit more important understanding the general information about the medications before we start talking about the medications that you can administer. So this is a little bit out of sequence from what you read in the book. It's the same slides, just a little bit reorganized. So the first thing we'll talk about here, the general information about medications. Each drug is going to be listed by its generic name. And then each drug has at least 3 separate names, one being a chemical name, which is kind of the fancy term. If you look in your book, it gives you the chemical name for epinephrine, which is a whole slew of words. And that's kind of the scientific, the chemistry behind it put together in a name. And then you have the generic name, and then you have the trade name. One or more trade names given to the drug by manufacturers can occur. So you have acetaminophen, and then you have Tylenol. So Tylenol is the trade name. Acetaminophen would be the generic name. In your book, they use the EpiPen as your example. Same concept. So when you go to the store and you see 6 different things that have acetaminophen or ibuprofen or any of those compounds in it, and then you see the different brands and they all have their individual name, that's what the difference is. It's basically the same medication by generic name, and then each individual company creates their own trade name that goes with it. So what do you need to know when it comes to drugs? You need to know the indications, so you need to know when you're going to use it. You need to know the contraindications, so you need to know when you're not going to use it. You need to know what side effects to expect, so that way you can kind of be prepared if you do give a medication in the field, what could happen if things go south, what are kind of some of the side effects that go with it, and then the untoward effects with it as well. This is another area where it is a good spot to build those flashcards, put the drug name on the front, and then put indications, contraindications, side effects, your drug dosages, your administration routes, all of that stuff on the backside, so that way you can study each of these individual medications. It's very helpful. Not a tremendous amount of meds at the basic level, but if you progress through any sort of healthcare field where it gets a little bit more complex, it is a very good study tool. And now you need to have an understanding, too, of what form the medication comes in. Some of these are going to kind of dictate how you administer the med. But real quickly here, you have compressed powders or tablets, and we'll talk about nitroglycerin pills. And basically, it's a powder that's pressed into some sort of a pill. These are the medications that if you take and you kind of rub them between your finger, they're going to go back into the powder form. You have liquids, which, like epinephrine in an auto-injector, is a liquid. You understand what liquids are. You have gels, such as a paste in a tube. So when we talk about oral glucose, it's kind of a little bit thicker product coming out. It's not a liquid, it's thicker than a liquid. So that oral glucose would be considered a gel. You have suspensions, which are kind of thick and slurry. And those are things like activated charcoal, which we'll still talk about. It's not widely administered like it used to be, but activated charcoal would be an example of a suspension. These are the ones that you have to kind of shake up and get everything mixed back up before you use it. You have fine powder, which can be some of the components inside of inhalers. You have gases, which we all know what gases are, but the prime one that we're going to use is oxygen. And then you have sublingual sprays, which you can also use. Sublingual meaning it goes under the tongue, but like the nitroglycerin that can come in a compressed powder or a tablet, can also be in a liquid form that you spray underneath the tongue, so it would be a sublingual spray. So talking about medication safety and clinical judgment, understand that medications are meant to help your patient. However, if they're not used properly, they can hurt your patient. So it is a big responsibility, even at the basic level with some of these medications, and understanding when you should and shouldn't give them, because things like nitroglycerin, if given in the wrong circumstance, can actually bottom a patient's blood pressure out and potentially kill the patient. So it's very, very imperative that you understand the medications. You know what they are, you know when to use them, you know when not to use them, you know what the proper doses are, and then use good judgment with this. The other thing to keep in mind is you always have medical direction that you can call. Next slide we'll talk a little bit more about that, but you never have to be the end-all decision maker. If you're not sure, you always have resources that you can go to. The medical authorization, now there's two different types here. So there's offline medical direction and there's online medical direction. Basically, when you're working in an ambulance, you're going to have a set of protocols that we've talked about previous. And those give you the ability to administer medications and do treatments through the offline medical direction. You don't have to speak to anybody. You're using the standing orders that you've been instructed to use based on whatever your system puts together as the protocols. And then you also have online medical direction, which is when you speak directly to the physician, or what's called an ECRN, which is basically RN that takes the radio report. They'll follow their protocols. They can give you direction. When there's a question, they'll go get the physician and they'll confer with the physician to make sure that everything's done appropriately. Like I said, you can work with the offline medical direction. If you're not 100% sure, though, there's nothing wrong with calling and saying, this is what's going on, this is what I have, this is what I'm going to administer, I want to make sure it's okay with you. And then you're kind of passing the buck on, so that if something goes south, you have direction to do it. If you get online medical direction, make sure that you listen to that order and then repeat it back. That way, you're clear on what they said, you repeat it back, so that way they can understand that you did hear them properly. If in doubt, ask for clarification, whether it's you didn't hear it, you didn't understand the dosage that they gave you, you think the dosage may be wrong. It doesn't matter. Whenever there's a doubt, ask for clarification and make sure. You're a patient advocate, so you're there to do what's in the best interest of the patient. But do make sure that you're using medical direction whenever you have questions. The 5 rights are going to be something that is utilized kind of universally across nurses, paramedics, doctors, and these are to help you make sure that you're going to give this medication, and it's kind of like your checklist before you give it. So do you have the right patient? Now, 99.9% of the time, you're only going to have one patient in an ambulance, but as an EMT, you may work as a tech in an ER. There are other things that you can do with your license where you could have multiple patients that you might have under kind of your wing. And so do you have the right patient? Is it the right time to administer the medication? So based on what you're giving and what the patient's condition is it the right time? Also, some of the medications that you have, you're going to administer multiple times. So nitroglycerin, you can give 3 doses is your max, but they have to be 5 minutes apart. So are you giving them at the right time? Is it the right medication? So you need to make sure, A, that you're given the right medication for what the complaint is, but B, that you've taken the right medication out of your bag. I have seen in my career the wrong medication given because one box was tan and the other box was kind of a little bit darker tan, almost a brown, and they simply grabbed the box based on color, didn't do the 5 rights, grabbed the medicine, administered the medicine. The patient had a side effect to the medicine. Then when they were troubleshooting, trying to figure out kind of what happened, realized that, oh, we completely gave the wrong medication to the patient. And then there was a whole follow-up process to that after the fact. But very important, make sure that you give the right medication. Is it the right dose? So all the medicines are going to have a specific dosage based on a number of things. Some are weight-based. Some are based on pediatric versus adult. So you need to make sure that you have the right dose. Luckily for basics, a lot of the stuff is kind of unit dose measured. So if you're given albuterol, it's 1 unit dose. If you're given an EpiPen, it's a unit dose. But the pediatric doses are still going to be different. So you do have to understand that. And the final thing here is, are you giving this medication by the right route of administration? So these medications work in a specific manner based on how you administer them. So like nitroglycerin is a sublingual. It's meant to go underneath the tongue and dissolve and then get into the capillary network to work to get down to the heart. If the patient swallows the medication, it's not going to do anything. So you have to understand the medications and what routes that they're given in, and then you have to make sure that you're administering them by the right route. So now that we've talked about the 5 rights, just take a moment and think about some of the potential risk if you don't utilize those 5 rights. You know, there's a whole multitude of things that could go wrong, from potentially giving the medication wrong and not making your patient better to potentially giving the medication wrong and killing your patient. So just kind of take a second to reflect on those 5 rights and think about what could go south if you don't utilize them in the right manner. Next thing to talk about here is going to be the routes of administration. So the first one is oral, and that's going to be basically anything that you swallow. So any pills that would get swallowed, anything along those lines. The next one is sublingual, and it is dissolved under the tongue. It is actually a very rapid method of getting the medication into the bloodstream. That's why it works real well for the nitroglycerin tabs with the cardiac patients, because it gets in there and it actually acts really quick. Next one would be inhaled, which means we're breathing it into the lungs. It's usually aerosolized particles from an inhaler or gas, oxygen. There's a couple different medications as basics that you're going to be able to administer besides oxygen that would be inhaled for different respiratory issues. And we'll go through these medications. We'll touch on them briefly, and then as we get through the different segments. So when we get into cardiac, you're going to talk more about the nitroglycerin. When you get into respiratory, you're going to talk more about the inhalers and things like that. Next one is intranasal, which means we spray it into the nostrils. This one is kind of I don't want to say it's a newer one, but with the use of Narcan nasally now, it's become widely available. So any of our overdoses that we can give Narcan nasally to, there's also some other medications at the higher levels that we use for seizures and some other things that you can give intranasally as well. And then one that you guys won't be doing, but you need to understand it and know, is intravenous. And that is when we put the medicine directly into the vein through an IV. And there are a number of medications at the advanced levels that will be administered this way. So you'll see it, you'll need to understand it. That will be a higher level thing that is done by the paramedics or advanced providers. A few more routes here. The intramuscular, which is injected directly into the muscle. You do have some at the basic level that you'll be administering this way. Subcutaneous is injected just under the skin. So compared to intramuscular, an intramuscular needle is going to be longer. It's going to go all the way into the muscle. A subcutaneous needle is going to be smaller, and it's going to go just underneath the skin. Another one that you won't be doing, but you will see, is intraosseous. It sounds kind of barbaric, but it actually is a really good way of administering medications. It's supposedly not painful to have interosseous put into your bone. I've never done it, nor have I had any interest in trying. But basically, this is when we take a needle as an advanced provider, put that needle right into the bone. There are several different bones that you can actually put this needle into. And then the medication flows in through the bone marrow and gets into the vascular network through the bone marrow. The final one, again, advanced level, but for your knowledge, is endotracheal, or sprayed directly into the tube that we would put into somebody's trachea. If you were at the hands-on Tuesday, we talked a little bit about endotracheal tubes. It was in the airway chapter as one of the advanced airways, but it's when that tube goes directly in the trachea and then you breathe for the patient. There are actually some medications that we could shoot right down that tube into the lungs, and then they enter the vascular network through the lungs. Pharmacodynamics is going to be the study of the effects of medications on the body. So what we're looking for is what effect will the medication have, how is it going to affect your patient specifically, and then the factors on how that medication works. So things like age, weight. Pediatrics are going to require usually a smaller dose than an adult, but there are also other factors that come into play. For example, at the advanced level, a patient that has renal failure, certain medications have to be processed through the kidneys, and if they have renal failure, it's not going to process like it should, so it's not going to have the same effects. So through all these studies of the effects of medications on the body, they can give you a little bit better understanding of how to expect those medications to work. Okay, let's talk just briefly here on reassessment and documentation. So this kind of falls back to a couple of the chapters we've already talked about, but how does it pertain with medications? So after administering a medication, you should reassess the patient, meaning you should have vital signs done before you administer a medication, and then shortly thereafter administering a medication, you should do vital signs again just to double check and make sure that it either worked the way you wanted it to, or that it didn't give your patient any side effects, because some of these medications you will pick up on in the vital signs. So you want to assess before, and then you want to reassess after. You're also going to assess things like the pain scale. So if you administer a nitro for chest pain, you want to know what the pain scale was before you administer it, and then you want to know what your pain scale is after. Basically, that OPQ or ST is kind of pertinent to the reassessment of medications. Now, as far as documentation goes, document everything. Think about the 5 rights and kind of use that as your tool for documentation. You want to include all of that. You need to include the dosage. You need to include the route. You need to include the time. You need to include all of that information in there. You need to document the vitals before, the vitals after. Basically, you can't document enough when it comes to medication, because you want to make sure that you kind of cover your own butt and that you've done everything right. Another thing with documentation is if you used your standing protocols or if you used online medical direction. You want to make sure to include that in there as well. So that's kind of the reassessment and documentation. All right, now to the fun stuff. So what is it that you guys get to carry and administer in the ambulance? Well, it's kind of a short list when you're looking at this. So aspirin, which is going to be used as a blood thinner for chest pain patients, oral glucose for diabetic patients. Oxygen is kind of for a multitude of patients, and it's kind of changed over the years. Now it's based on need and kind of what their oxygen levels are. It used to be that, well, you can't give anybody too much oxygen. That has changed. It is actually detrimental now for certain things like strokes and some other situations to give too much oxygen. Activated charcoal, like I talked about, you will learn it. You may carry it. It's kind of gone away in a lot of systems, but this is going to be for overdoses, and kind of the purpose behind it is that it binds all of those chemicals in the stomach together and pushes them through the digestive tract without being absorbed into the body, so that they actually kind of avoid the poisoning part of it. And then the last one, which has become more common over the years, is naloxone or Narcan, which is what is used to reverse the effects of certain drugs like morphine and other street drugs that they will overdose on, like heroin. So we'll run through these kind of one by one, show you a quick picture of some of them, and we'll go from there. Okay, first medicine here, aspirin. We're going to administer this medication orally. It is going to be used for chest pain patients where you suspect that it is a cardiac issue. Basically, what the aspirin does is it reduces the blood's ability to clot. And what a heart attack is when there's a clot in the arteries surrounding the heart and doesn't allow blood to flow to those certain segments of the heart, and it'll start causing damage and eventually death. So what this does is kind of prevents the clots from happening and lets that blood get through a little bit easier. There are other blood thinners that they use in the hospital setting, but from an EMS standpoint, aspirin is what we use. It is going to be baby aspirin, honestly, and what they do is chew it up, and then it kind of gets absorbed in through the body. Next medication is oral glucose, and this is basically sugar on steroids. It's completely edible. You can open this and eat it. It is going to be super duper sweet, but basically when you use the glucometer and check your diabetic patient, if their blood glucose is low, and there's a need to elevate that blood glucose, we'll use this oral glucose as the method to increase it. It's also given in the mouth. It's actually a route called buccal, where you put it in between kind of their gum and their cheek, and it absorbs in through the capillary network right there and will help boost their blood sugars. It's not super fast acting. Don't expect your patient to kind of have a big increase in their blood sugars really fast. For that to happen, you'd actually have to use the intravenous version of dextrose, which you guys won't do as basics, but this is a tool that you guys can use. Sometimes people will also have their own glucose tabs that they can utilize to help increase their sugar as well, but this is that gel that we talked about. Like I said, you can eat it. It doesn't taste the best. There are different flavors. I've been told some of the flavors are better than others. So this is drug number 2. Oxygen is next on the list. It is a gas. It is what you breathe in and out every single day. The atmosphere contains 21% oxygen. When you exhale 16% oxygen back out. So it's out there in abundance, but you will have the need if a patient is hypoxic or in danger of becoming hypoxic, which you're going to utilize your end tidal numbers if you're capable, and then your pulse oxes to determine if you need to administer oxygen. Like I discussed earlier, it used to be you just gave oxygen to everybody. Everybody got a non-rebreather. Everybody got 15 liters of oxygen. but studies have shown it is detrimental from anything from strokes to COPD patients. You don't want to overload them with oxygen. So you do have to understand when to use it and how to administer it. We did go over a few of the different methods in class. They're showing you a picture of the nasal cannula, which is the 1 to 6 liters through the nose. You can also administer it through a simple mask, through a non-rebreather. We'll apply it to a bag valve mask if we're helping to oxygenate the patient through those means. So a number of different ways. We'll cover more of this when we get to the resuscitation chapter. We should also cover some of this in the respiratory chapter as well, on top of what you've already learned about oxygen. All right, activated charcoal. And for any of you that have ever seen or cooked on a charcoal grill, charcoal is black, charcoal is nasty to get all over you. This is a liquid version of charcoal, more of a gel version, but it's thick. It gets all over everything. It stains everything it touches black. It is black when it comes out of the tube. It's very, very nasty. They say it tastes horrendous. So if you've had a patient that's overdosed, they drink this once, they're likely not going to want to overdose ever again, just because they won't want to have to do this. However, in today's day and age, they've kind of gone away from this because it can cause the patient to vomit, and that can create other issues. You don't want to induce vomiting anymore with your patient. They can give this through what's called a nasal gastric tube, which is the tube that goes into your nose and down into your belly. I have seen it given that way as well. But just be prepared if you have this on your ambulance and you're going to have the patient take this. Be prepared for vomiting. Be prepared with suction. The purpose behind it is it binds the elements of certain poisons so that they can't be absorbed into the body, and then they get passed through through waste, through stools and other such means. So this is what activated charcoal is. All right, naloxone, also known as Narcan, and it is widely available. You can basically go into a pharmacy now and pick up naloxone, and it's basically the way that they're trying to prevent overdose deaths. I have mixed feelings on it because, in a sense, it kind of enables people to think that they can take more drugs, and worst case scenario, they have the naloxone, somebody gives it to them and it reverses them. Problem is, it doesn't always work that way. It's not a cure-all. But it is specific to narcotics. You can give this through a few different methods. Most commonly for you guys as EMTs, you're going to administer it intranasally. So you're going to put a little atomizer on the end of the Narcan tube, and then you're going to squirt it up into their nose like a nasal spray would be. It only works for narcotic, and you kind of want to use it in specific situations where you cannot control the airway. So if they're unconscious or in respiratory failure, you can use this to try to reverse. It does work quickly if they've used a narcotic, if they've used heroin, fentanyl, something along those lines. This does work very rapidly once it gets into the system and kind of blocks out the effects of that drug. And they will wake up, they will start breathing. Be prepared for an agitated patient. Once you reverse it, you've taken away their high, they're going to be angry. Be prepared for vomiting with it as well. That's another common side effect. If they've taken something else that causes them to be unconscious other than a narcotic, this isn't going to work. You might as well be putting water up there because this is only specific to narcotics. So there are three prescribed medications we'll talk about here. One is the inhaler for breathing problems. One is nitroglycerin for chest pain believed to be a cardiac problem. And then the last one is the epinephrine, which is going to be for the allergic reaction. So just had to switch computers, so hopefully this continues and there isn't like an issue with the transition from one computer to the next. But if I sound differently at all on this computer, it is going to be because I just switched computers. Or Fred, if I sound monotone still, that's just what you have to get used to. But moving on, the next thing is going to be prescribed medications that you are assisting with. So the first one is a bronchodilator inhaler. You will see these commonly with asthma patients, COPD patients, where they have an inhaler that they can use. Basically what this does, if you go back to the airway chapter, when we talked about the different things, and one of those being the bronchioles closing off, spasming down. This bronchodilator will help to open it back up. It's not real long lasting with this usually, but it does give some temporary relief till you can get some more definitive care. The one thing that you do have to keep in mind with all of these assisted prescribed medications is make sure that they are your patient's medications. So go back to your 5 rights and make sure that they are for your patient and not Sister Susie or Aunt Jane, because that is a common thing you're going to find in EMS. Well, I have an inhaler because I have asthma, and so was having a hard time breathing, so I gave him my inhaler. If they've done that, there's nothing you can do about it. But what you need to do as the EMT is make sure that it is the patient's if you're going to assist them with it. Again, it just goes back to the 5 rights. You got a real life scenario there with the pager going off and throwing me off in the middle of the slide, but you kind of got the gist of things. Kind of continuing here with the bronchodilator. Like we said, it's used to enlarge those bronchioles within the lungs and air pass through a little bit easier. So the main places is going to be asthma, emphysema, and chronic bronchitis, which emphysema and chronic bronchitis kind of form together to make COPD, but these are going to be the common places. Typical side effects you're going to see with this are they are going to increase the patient's heart rate. That is normal with the action that they do on the body. And then with that, it's going to cause them to be jittery, kind of restless, might make them feel a little bit amped up. That's not abnormal. So you do want to use this with caution. If you should check their baseline vitals, like we've talked about, and if their heart rate's already in the 120s, 130s, before you give the bronchodilator, you might want to call medical control, make sure it's okay, because if the side effect is that it's going to increase the heart rate and their heart rate's already elevated, do you really want to elevate it even more, or is there something else that you can do? So use your resources. Next one here, a couple slides talking about nitroglycerin. So this is going to be the spray version, and basically you have them open their mouth, lift their tongue up, and you give them 1 squirt underneath of the tongue. If it doesn't quite squirt out properly, it still counts as the squirt. You do have to be careful here. It's not like a breath freshener where you can just keep squirting it, and it's the more you squirt this, the more medicine you're giving them. So that is one thing to keep in mind with this. Like I said, this is the spray version. There's also a tablet version that goes sublingual, also under the tongue, but you let that one dissolve. We'll talk a little bit more about kind of what the nitro does here on the next slide. So the nitroglycerin is going to be taken by patients with a history of chest pain that is cardiac origin. So that's going to be your indication. Chest pain and believed to be cardiac. What nitro does is similarly to the inhaled medications that kind of open up the bronchioles. Same concept, except now it's opening up the vessels around the heart. to help blood get through a little bit easier. One of the contraindications is low blood pressure, and if you're taking medication for erectile dysfunction, like Viagra, Cialis, anything like that, it's also a contraindication because the effects of nitro can lower your blood pressure in certain situations. And it's the same thing that Viagra and Cialis, that can also on their own lower your blood pressure, so putting them together kind of amplifies what it does. So that would be the side effect that goes along with it. They say it tastes metallic. It will give the patient a headache because it does open up the vessels around the heart, but it can't dictate to just say, hey, open up these specific handful of vessels. So it will also open up the vessels in the brain, cause that rush of blood, which is going to give them a headache. That's very normal with this as well. All right, and the last one here is the epinephrine auto-injector. And this is going to be for those severe allergic reactions where the patient's throat could potentially close off and cause an airway issue. This is going to be a medication that is going to go in and act as a vasoconstrictor. And basically it is an intramuscle injection. So there's some safety mechanisms, and when you depress it against the leg, it shoots the needle into the muscle, dispenses the medication into the muscle, and then the needle and everything retracts back up into these devices that you see here. So it can be a safety hazard for you because you could inadvertently get injected if you don't use it properly. So you do have to use it with caution. But that is the process. It's supposed to be a fairly safe thing as long as you know how to utilize it. So oftentimes, if anybody's had an allergic reaction, they will have these epi auto-injectors. Now there are specific injectors for pediatric patients, and there are specific injectors for adults. So make sure that you're utilizing the right injector on the right person, because the dosage is roughly, it's half for the pediatric dose. So it may not work on an adult, and the adult dose is going to be obviously twice as much as what the pediatric patient needs. So you could cause issues if you're using it in the improper manner when it comes to that. But basically what it does is it's a vasoconstrictor, so it relaxes the smooth muscles. So it's going to relax those muscles around the airway passages, let things kind of open back up so the patient's able to breathe on their own much easier. That's the desired effect. Side effects are that it will increase the heart rate, it will increase the blood pressure. Those are to be expected with this, but when we get into the chapter on allergic reactions and go through all the different signs and symptoms that go along with it, you'll understand a little bit more, and then this will play into that chapter on when to use it. Force protection medications are going to be medications that you use in the event of an attack. So these are going to be used to protect yourself primarily. So in certain chemical nerve agents, you can use these atropine auto-injectors. Basically for organophosphate poisoning is what it's going to be, and it'll reverse the effects of that. So potentially, depending on what system you're in, where you're at, what's going on, you may be exposed to these, and these are going to be self-protection mechanisms in case of an exposure. Another just quick thing that they talk about here are understanding that there are certain medications that are used for daily use and not in the event of an emergency. So Advair is an inhaled medication, but it is specific to daily management. If you try to use it for an emergency treatment, it doesn't work in that manner. So just knowing the drugs, understanding the drugs, hopefully your patient knows what drugs they're taking, what they're for, when they should be used as well. and hopefully they can give you some insight into that. And then kind of the final slide on this topic is talks about herbal agents. And this chart kind of goes through a few different herbals and kind of what they're used for. In today's world, it seems like you can get an herbal supplement for every single medical condition known to mankind. So when you are transporting your patient, the main thing to know is what prescribed medications they take. But if they are big into the herbals, it is pertinent to kind of make a note of these and take it to the hospital, just so that the physicians there have an understanding of everything that they take and do, in case there are some medications that maybe interact differently together. But herbal agents have become kind of a new fad over the last 10, 15 years or so. And basically, you buy these over the counter, and they say that these are supposed to cure all these other medical conditions. There probably are some good effects with some of these. Some of them are probably sales gimmicks, but they are out there. You need to have an understanding of them as an EMS provider as well. All right, last segment for this chapter. And again, this is going to be an advanced level piece of equipment. But as an EMT, it is very pertinent for you to know, understand how these work. You can assist the advanced providers in getting things set up. You just can't do the actual task of starting the IV. So basically, these fluids and medications can be administered into the vein. You're going to take an IV needle, you're going to insert a catheter into the vein, and then more times than not, the first thing that's going to hook up to that catheter is a saline lock or heparin lock. And basically what that is you have the catheters placed into the vein. There's a little port that sticks out of the skin then, and then this small piece of tubing that's 3, 4, 5 inches long will hook into that port, and then that is kind of a self-contained unit to where you can administer medications through it, you can hook up fluids through it, and then you have access to the IV right there. Again, advanced level piece of equipment, starting the IV, advanced level medication administration, giving meds through the IV. That's not something that you can do, but these are things that you get to assist with, so it's pertinent to learn and understand. So we've talked about the actual insertion of the IV and the port that sticks out. We've talked about the saline lock that hooks up to that. Now, fluids and medications can be administered into the vein, but you can also have a traditional IV bag hanging, and what this is it's a bag of fluid. Most commonly, it's 1,000 milliliters. But they do make 500 milliliter bags, and they make other size bags as well. Most commonly, you're going to find 1,000 milliliter bag. It hangs up above the patient. It will have a string of tubing that comes down, and we'll talk about that on the next slide, and that hooks into the saline lock. And then you can continuously flow fluids and or medications, not generally in the ambulance. There are a few at the advanced level that will administer through the IV drip method. More commonly, it's just the fluids, but those fluids will flow into the vein through this whole network of tubing. And most commonly, what we'll use is what's called normal saline, which is just salt water, and it's what basically most of your body is composed of. And then that flows into the body. There's a couple different fluids too that you guys don't really need to worry about at this point. But that's how the traditional IV bag works. So like we talked about, the clear plastic tubing connects up above to the fluid bag, and then it runs down, and then it hooks into the extension set, the saline lock, which hooks into the needle or catheter. There are 3 components of the tubing that you need to be familiar with as a basic. That is the drip chamber, which is there's going to be a little chamber of fluid that actually pushes into the big bag of fluid. So this is just going to hold a few cc's of fluid below it. If you squeeze that, it'll pull fluid down from the bag and it'll drop into that. And then from there it flows down into the tube. It's important to have that chamber um, filled, not all the way, but it'll have a marking on it about a third of the way or a half of the way. You want that much fluid in it because that prevents air from getting into the line. Air in the bloodstream is a bad thing. Then you'll have your flow regulator, which is usually a roller clasp. And basically what that does is if you roll it one way, it cinches down on the tubing and pinches it shut. If you roll it the other way, it comes off of the tubing, opens the tubing wide open so that fluid will run freely through. And then you can regulate that in the middle to control how much fluid is coming out of that bag and going into the body. It's kind of a feel situation. But you'll watch the number of drips that are dropping into that chamber, and then that gives you a flow rate. So at the advanced level, you learn about that stuff. For you, it's more of a knowledge base. The last thing that you're going to need to know is that there are drug or needle ports. These days, there are safety ports, so you screw the medication into the port, but there also may be some uh, plastic hubs that almost look like the skin of a drum. And basically, you can stick a needle through that. When you pull the needle out, it self-seals itself back up, but you can push medicine or whatever you need to into the tubing that way as well. So next time we have an in-class, you'll understand this a little bit more because we'll go through it. There are a few images coming up here that kind of explain a little bit of everything as well. So one thing that you will do is you'll be able to set up the IV fluid administration set. So this is what looks like a 500 ml bag of fluid, and what this EMT is doing is they're inspecting the bag, making sure it's the right solution. More times than not, it's going to be sodium chloride, 0.9% sodium chloride, but they also make what's called lactate ringers. They make D5W, which has some sugar in it. So you need to make sure that you have the right fluid. You want to make sure that it's clear, that it's not leaking. You need to check the expiration date. Basically, anything that you would do with the medication, you need to do with this fluid as well. The next step in setting up that IV fluid administration is you take the tubing out of the bag. So what this is he has that drip chamber in the right hand, and he's pulling that protective cap off, and basically that plastic needle is what is going to poke into the bag of saline or whatever fluid that you have that you're going to be administering. It pokes in the bottom of the bag, and then when you squeeze that bulb, it starts pulling fluid from the bag into the tubing. And then you control that with the roller clamp. So what we call it is spiking the bag, because you're taking the tubing, you're spiking it into the bag. Do keep in mind you don't want to contaminate any of these things that you're poking into the fluids that would be going into the human body. So, with caution, you want to do all of this. You don't want to pull that cap off and then let the tubing fall down on the floor where it can pick up bacteria or whatever else, and then stick it into the bag, because you could be putting that bacteria into the bag, which could in turn be putting it into the body, which could be detrimental to your patient. So common sense goes a long ways with this one, but that's kind of the purpose of it. Next step, like we talked about, you take that plastic needle above the drip chamber and you literally spike it into the end of the fluid bag. Get it pushed up there. You'll be able to see it, but get it pushed up there nice and far so that it gets into the fluid and can draw it down. And then the other thing is that you don't want it to be leaking out around where you insert that into. Now, if you look at the bag that they're putting it into, there are going to be two different ports right there. It's pretty common sense, pretty self-explanatory. One of them is kind of a female end where you stick this spike up into, and then the other one is kind of got that kind of like a drum with the skin of the head across it, and that is where you could put a needle up into the bag and either put medication in there or draw saline out of there, and then when you pull the needle out, it seals itself back up so that it doesn't leak. So now you've got the bag spiked. You've pushed that white plastic needle up into the bag of fluid. You've pressed the drip chamber to fill that drip chamber up about halfway with fluid. Now you open your roller clamp and you watch that fluid go all the way through the tube. You got to make sure that that fluid gets all the way out to the bottom, and ideally you want no air bubbles in the tubing, or very minimal air bubbles in the tubing. Like I said, ideally no air in the tubing, because whatever's in that tubing, when you hook it up to the body, into that saline lock and into the actual IV, that's what's going in the body. And you can kill a patient with an air embolus. So if you forget to run the fluid down the tube and then you open up that bulb, the pressure shouldn't let it flow in there. But if you squeeze the bag or whatever you do to manipulate it, you could push that air into the bloodstream, which could potentially kill the patient. So again, just a lot of attention to detail when you're setting up these IV fluids. And then finally here, once you've run the fluid all the way down, clamp that roller clamp back shut. It'll stop the flow. It won't let any of the fluid below the roller clamp flow out as well, so you don't have to worry about what's distal to the bag and the roller clamp draining out and then having air in there. And then the paramedic or advanced level provider will hook up the end of the tubing into the IV port, and then they will control that roller clamp to set the amount of fluid being taken into the body based on their knowledge. So again, something that you can assist with, something you need to know. It is a good skill to have, but basically this is the idea of setting up an IV fluid administration. Final slide here, talking about maintaining an IV. And again, a lot of this will fall back to the advanced provider, but as a basic, you should be able to recognize if there's a problem, and you should be able to help troubleshoot those problems. So when we start an IV, we put a tourniquet on the arm proximal to where the IV is being inserted. The purpose of that is to build up some pressure in the vein. It makes that vein bulge up, makes it easier to get the IV started. If you forget to take that constricting band off, it will affect the flow because the tourniquet is working like a tourniquet should, and it's not letting blood flow past it. If you have taken the constricting band off, the next thing to do is check your roller clamp. Make sure everything there is working properly, it's not pinched off. Make sure that the roller clamp is where it needs to be. From there, just work your way from top to bottom on the tubing. Make sure that there's no kinks, make sure it's not caught up under the pavement, make sure that there's nothing that could potentially be pinching that tubing off. Usually if you have a flow problem, and it's not because the IV was started improperly, these are going to be what you're going to usually find. Now, there is the potential that the advanced level provider starts an IV and misses the vein, and when they hook it up, it's not going to flow because there's no place for it to go. So as long as the IV is patent and where it needs to be, if there's a flow issue, these are the things that you're looking for. You want to make sure that you get that flow rate adjusted to the proper setting, and then you want to monitor the IV sites for what's called infiltration, and that is, like I talked about, when the IV is missed. If it does flow, the skin around it is going to kind of poof up because it's all that fluid that's getting pushed in there is kind of building its own little hematoma around the area. You want to look for redness. You want to make sure that it's not burning when it's going into the patient. If that's the case, the paramedic should discontinue the fluids and more than likely discontinue the IV, and then they'll have to make another attempt someplace else to start the IV if they need one. So that is the maintenance of the IV. Now we've reached the chapter review. Like I said, these are kind of the generic list of medications that you will have as an EMT basic. You could be exposed to more depending on where you work, but from a national standard perspective, this is the list of medications that you're going to need to know. When we have our next in-person, we will have all of these medications out so that you can see what they look like, see how they would work. We have some EpiPen trainers so that you can practice with an EpiPen, kind of just get your hands on everything and see it. And then as we work through the medical chapters, you'll start seeing how these medications fall into place to the specific medical conditions. So when we get to the airway chapter, you'll start seeing the bronchodilators, you'll start seeing the oxygen. We get to the cardiac chapter, you'll start seeing the nitro. It'll talk more about that. When we get to the diabetic chapter, you'll see more about the glucose and so on and so on and so on. But basically, look through the chapter review. This isn't a very long one. I don't expect the actual lecture to be probably 30 or 40 minutes once we get it put together all the way. And then the quiz will be specific to just pharmacology. So if you have questions, throw them out there. Otherwise, we'll keep plugging away. You're all doing great so far. So keep up the good work and keep moving forward.